Hello, my name's Joel Dunning and I'm here at EACTS 2023 and I'm delighted to be with Professor Jim Tatoulis. Jim, you're hugely known all over the world, Director of the Royal Melbourne Hospital, a complete world expert in arterial revascularization and everything that is CABG. I read that you've done 12,000 operations over the course of maybe more than 3 decades. So it's a real honour to be with you here today. And I think you've just been at the CABG Academy, where you've been here doing some great talks about the specific techniques of CABG, and it's that we'd love to talk to you about. And I think the talk you gave was all about what does a surgeon do with a coronary aneurysm. So maybe what did you tell the Academy about that?
Thank you, Joel. Firstly, thank you for having me on. I guess I started young, and so together with my colleague Brian Buxton, we started arterial grafting back in 1981, believe it or not, so over 40 years ago. We learned things. Each step was about sort of 5 to 10 years in the learning, so it didn't happen overnight. But anyway, it's been a great ride so far. Specifically with coronary artery aneurysms, in fact, it's an interesting topic because it covered something that we as surgeons don't come across very much. They're very unusual. So when routine angiograms are done for coronary artery disease, roughly about 3 in 1,000 will show a coronary artery aneurysm. So the question becomes what to do with them. And if I can simplify to sort of 3 or 4 things. One, we should do something about them because they're usually associated with a 50% higher incidence of mortality or a major adverse cardiac event. So they really should be treated appropriately. And there's really 3 things. If they're small, and by small I mean less than 1 centimetre in diameter, and particularly if they're fusiform, like just elongated, then probably anticoagulation type of medication is the best. And there's no clear answers whether warfarin or the new anticoagulant medications or dual antiplatelets are best. There's no clear evidence for one over the other. If they're of medium size, and I would say somewhere between 2 centimetres and 3 centimetres, then most of us would probably advocate ligating with the suture ligation above and below the aneurysm, and then grafting distally. And then the more interesting category, the giant ones, which are usually more than 3 or 4 centimetres, and often up to 7 or 8. They're huge aneurysms, and those normally would advocate to actually open them up and really sort of tackle the issues from the inside, because it's easier to define the inlet and outlet. And also, sometimes they have side branches which you might need to individually ligate, or sometimes they're really big, you might have to bypass those as well. And of course, when you do that, you always have to bypass the vessel distally.
So you'd actually, if you found a really big side branch in the middle of the aneurysm, you might even once or twice in your career actually put a graft onto that?
Oh yeah, yes, absolutely. I think you have to work out where it is and in relation to the aneurysm, etc. But yeah, if it's a sizable side branch, yes, you would certainly graft that.
Wow, that sounds great. And what were your other takes from that session in the CABG Academy? What did you guys talk about, and what were your take-home thoughts?
Well, I thought it was a really good session because, as was pointed out, instead of talking about the routine stuff, it really came to unusual problems which we were all confronted with. And because each of us has a very limited experience in all these areas, like in my whole career, I've only done about 8 big coronary artery aneurysms over 40 years, and I think that's the same for most people, that I think it's important to get other people's perspective on things which are rarely seen. And so I thought the talk by John Puskas on both endarterectomy, but more importantly on stent endarterectomy, where the LAD had stents from the left main right down to the apex, and showing how that could be successfully removed and bypassed. I thought that was terrific. Anomalous coronary arteries, I think we're starting to see more and more with routine or common CT angiography now, and I think they're coming to the fore, and I think it's important to distinguish between ones which are sort of innocent and those which are possibly more lethal and how to tackle those. So I thought that was a very good session. And of course the controversy about the second arterial graft, whether it's a Artery or a radial artery, and I think the randomized evidence is gradually pointing to the fact that probably a radial is as good, if not better, than a Rita, not because of the inherent nature of the conduit or its physiology, but I think because of the ease of use and the length. I think that the radial artery is shaping up to be a much more versatile vessel, whereas the Rita is an excellent artery, and just as good as the left internal thoracic artery, but it's stymied by the fact that it'll only reach to certain areas, and it's a bit smaller, so therefore its versatility is not as great.
So in Melbourne, what is the 2023 best operation that your average 75-year-old chap with type 2 diabetes, what are you going to do for them in terms of grafting and methods?
Well, our pretty standard operation in people over 70 would be definitely a left mammary to the LAD, a left radial, usually 95% of the cases, to the next best vessel, and that's usually to the circumflex, but occasionally to a tightly stenosed or occluded posterior descending. And then we might use the second radial, although not as much as we did before now with catheterization of those radials, or a vein graft. And I would put in a plug for vein grafts. I know I'm known for arterial grafts, but certainly the vein from the angle up to sort of the knee is usually excellent vein in most people. Often has no or just one or two branches, and often has no valves. So if you're going to use a bit of vein, that generally is the best bit of vein. And that I think in the RAPCO study that we did, which was the biggest randomized study of vein grafts versus radial arteries, for the second vessel, it really showed that the vein grafts held up pretty well up to 10 years. And of course then the radial artery sort of outperformed it over the 15-year period. But in that study, we followed up every single patient to 15 years or more. So it's very good information.
Do you have any views on harvesting technique? There's this no-touch technique, and there's endoscopic and open. What are your thoughts on that?
Well, with the radial, because we're predominantly teaching hospitals, and we have the fellows rotate through about every 6 to 12 months, endoscopic teaching is pretty difficult. So we do it open, basically, and predominantly now with harmonic scalpel. So that's been a terrific technique.
And just on the vein grafting thing, there's a lot of talk about no-touch techniques for vein grafts. Do you think that's important? Or?
Well, it depends what you mean by no-touch technique, but the no-touch technique that's come out of Sweden, where there's a layer of fat and the vasovasora preservation, is very good conceptually, but it does lead to high leg infection rates and also, I guess, long scars in the leg. And I would suspect, certainly in the United States, it would be very difficult to coax patients back to open vein graft techniques as opposed to endovascular. I do think endovascular techniques cosmetically are better, but I think from a purely functional point of view, I think they're still not quite producing the same results as open vein harvest.
Yeah. So obviously there's quite a big controversy about the ACC guidelines. They've not really given the full level of priority to triple vessel grafting in people with good LVs, which obviously led the SDS members on that committee to leave that committee. You know, I guess you're an outsider in a certain way, but obviously an insider in that you want people to be told the best evidence. So what are your thoughts on that situation and where we can go from here?
Well, you've probably had other comments apart from me. I do think it does take about 10 years or so to really get good evidence that one revascularization technique, whether it be one mammary versus two, or whether it be stenting versus arterial grafting. And I don't think the different studies that they base their recommendations on were really long enough to be able to make that call. So I, with others, would disagree that with some of their sort of conclusions. I think there's no question in my mind that coronary artery surgery for most people with extensive coronary disease is better, and having two well-functioning arterial grafts is better still. If I can just say something, I'm often asked, why is it still only 5 or 10% of people in different jurisdictions, particularly the United States, only getting 2 arterial grafts, and I think that's a bit disappointing, but nevertheless, I think the way to rectify that situation is really to really advocate the fact that the radial artery is probably the easiest second graft to use, both to harvest simultaneously with the left mammary, but also if I could make a plug for just using it exactly as you would use a vein graft. Whatever you do with a vein graft, just do it with a radial, and I think after 10 years you'll probably see a big difference both in patency and results.
Yeah, and I guess you brought up a very good point about coronary catheterization. It's all radial now, isn't it? So they do tend to wreck the radial arteries. So when do you avoid using a catheterized artery, and when is it safe to use it again?
Well, I think that is the issue for the ages. I think the important things are, firstly, that the cardiologists don't actually puncture the radial artery at the wrist. They puncture usually 3 or 4 centimeters further up. The sheath is about 10 centimeters long, so it goes at least halfway up to the elbow. And I think there's good evidence that there's trauma and there's endothelial dysfunction and other physiologic problems with those grafts. So in general, we try to avoid them for about 3 months if we can. Very occasionally, if there's conjugate shortage, then we'll use the upper third or upper half to do a side branch or maybe wide grafts. But in general, I think it would be wise to avoid a catheterized radial for at least three months if you can.
Yeah. So I suppose finishing off, I suppose if you had one message to the, somebody who does a lot of CABG grafts, I suppose if they're doing one artery and needing to progress, your message is get to that second radial. I guess occasionally use the Rita as well, but would that be your message to people who haven't yet sort of embraced this? And maybe as a question, like I can hear them shouting, say, why would you do that in an 80-year-old person? So why do a second arterial graft if they're 82 years old?
Well, I think there is firstly evidence that is emerging that even people in their late 70s and even 80s probably do better with 2 arterial grafts, the 2 best vessels. But as I said, it's hard to predict how long someone's going to live, and certainly even in octogenarians, avoiding incisions in the leg allows those older people to heal quicker, to ambulate faster, and to get out of hospital more rapidly. And the forearms heal really, really well, very rare to get infection. So leaving aside all the patency and prognostic issues, I think just from a practical point of view of comfort and getting people out of ambulating out of hospital, it's a much better operation. So for any surgeons who are about to embark, would like to embark, the disc make a plug again. The left radial, all things being considered, I mean, there are obviously some contraindications, particularly small vessels or very calcified vessels, but the second radial used exactly as they would use the vein graft would do good justice to the patient.
Yeah, I'm just itching to ask a few more from the world expert in the radial artery. When would you not, from a pulse test or put a SATS probe on, or how do you decide when a radial isn't suitable for use? Because there's a bit of controversy on that, isn't there?
Well, thank you for the question. Just to the outset, I think if someone's had significant trauma to the forearm, and if they've had Raynaud's or collagen type of disease, polyarteritis and those SLE, we probably would not use it. And also if the radial is small, less than 2 millimeters, we would not use it. And we just routinely use the Allen's test, both clinically, but also in the operating room. Just before we harvest it, we put a plethysmograph reader on usually the index finger rather than the thumb, and then do an Allen's test and return of the wave in the index finger within 15 seconds. We would definitely use it. If it's very calcified, obviously we would not. But in our experience of over 20,000 radial artery grafts, and I don't want to sound conceited, but it's been a big experience. We lost 2 fingertips early on when we didn't appreciate the issues about polyarteritis and SLE. In fact, that's why we use it, because the legs were awful. So we lost 2 fingertips early in our experience, and we've had one case that I know of where the patient developed some hand ischemia about a year later, and I think they'd gone to live in a cold climate, and there were sort of issues there. So we reconstructed the radial artery with a vein graft, ironically. So.
Wow, well, 3 in 20,000's not bad, isn't it, with those rules? The Allen's test in 15 seconds and those rules. Well, it's been absolutely wonderful speaking to you. It's been amazing. You've done such an amazing job for the teaching of CABG worldwide and promoting total arterial grafting. So for myself, Joel Dunning, and everyone at CTSNet, thank you very much for talking to us. It's been great.
Thank you very much. Thank you for having me on, and hopefully some of what I said made some sense.